Wonderful.
Best from Croatia.
Hello, hello from Barcelona.
Hello from Bremen.
Huh. Rainy.
So nice to have you all. We would like to welcome you all to our first BEGO Implant Systems webinar for professionals. We are very excited, very happy about this new project. And today we are speaking for more than 30 countries and more than 300 participants, which make us very, very proud, including Philippines and Iran, where we have hybrid events. This is very nice. It's a big pleasure for us to have as our first speaker our friend Dr. Sinejana Po from Croatia. And Dr. Sinejana Po will talk today about partial extraction therapy for we all. And we would like to thank you very much, Sinejana, for accepting this invitation to be our first speaker. Also like to thank Mr. Uwe Justinmeier, our colleague that is behind the scene and take care of everything, and also Mr. Darian Prokop from Croatia for the support in giving us all this event. So I give you to Uwe and Sinejana Po.
Okay, Dr. Pohl.
My turn, I guess.
Yeah, your turn.
I accepted your invitation very, very gladly because it is my favorite topic, or one of my favorite topics, partial extraction therapy. And Uwe, tell me, have you already asked the question how many of participants have heard about partial extraction therapy?
No, actually, we are doing it right now, and I ask all participants to fill in the questionnaire.
Mm-hmm.
And
I see you have 83 participants, 84, and it would be really nice to know how many of them do know about partial extraction therapy, and even more interesting, how they know about it. What is the source?
And we have now 50% voted. We wait another few, and then we will close and we will launch it.
Okay.
So we have 60% now. Then I close, and
yes,
I hope you can see the answer. Already heard 84% of socket shield, 29% of root submergence therapy, 20% of pontic shield, and 49% of partial extraction therapy.
Perfect. And do we already know the sources? How do they know about it? The journals, the books, friends, colleagues, dental XP?
Yeah, I just prepare it. And now, please, participants, answer how you got to know from this. And again, we have the votes.
I know about partial extraction therapy from Forum Dental XP, and it can also explain why I have so a low complication rate, because I followed really Chuck Swima, Howie Gluckman, Jorge Campos Aliaga, Dr. Salama, and my basically today pet research group, and they shared really very openly their complications. So I've learned from their complications, and I have very, very little complications nowadays.
I think that's the best way to learn from the mistakes of others. So we have 60%, more than 60% votes, and now I would like to share. 47% know this subject from dental journals, 40% from congresses, 32% from friends, 28% from social media, and 21% from Dental XP. Okay, now over to you, and I will see you later on.
See you later. So let's talk about partial extraction therapy. Let's try to guess where is the implant here. And mostly after partial extraction therapy is done, we can guess where is the implant only on the crown, only white aesthetic, not a pink aesthetic, because pink aesthetic is always perfect. Partial extraction therapy.
Dr.
Yes.
Pohl,
Yes.
can you show your screen that somehow I think it cannot be seen?
Mm-hmm.
Yeah.
Okay, I'll
Just
try
share.
again.
Yeah.
Yes. So
Sharing the screen.
Sharing. I go to sorry. Now?
Yes, perfect.
Perfect. Okay.
Super.
Okay, beautiful. You haven't seen the first slide. Now you have to see the first slide. Okay, anyway, partial extraction therapy. It was one of the pool questions. It is not only socket shield. This is socket shield, Pontic shield, and root submergence therapy. All of these treatment modalities. And now, Uwe, I'm sorry, I have a problem because I cannot change the slides now during I'm talking. Can you help me now, please? Sorry to all participants.
Yeah,
When
no
we have
worry.
done a test, it worked perfectly. I have bought my
Yes.
pointer and I have my arrows on my
What yesterday you stepped out of it and you showed just your normal screen. You stopped the presentation, and maybe you try this again. Just step out of it and
yes, now it
start
worked.
again.
Okay, now it works. Haha. And this is this. I love to give lectures about partial extraction therapies, but I'm not so happy about giving webinars because of this technical stuff. But now I have Uwe and nothing can happen. Okay, partial extraction therapy is not only socket shield therapy, but the most of us already know. It is also Pontic shield. Pontic shield, it means it is socket shield without implant placement. What for do we need for Pontic shield? It is to maintain the rich volume in the Pontic site. Not always we place adjacent implants, not always we place implants, but we want to preserve the ridge. And we can utilize Pontic shield or we can utilize root submergence therapy. These are treatment modalities of partial extraction therapy. Let's see them live, all in one patient. Root submergence therapy for both central incisors. Socket shields for both lateral incisor and for the left canine, and Pontic shield for the right canine. All these therapy modalities shown in one patient. Why do we need partial extraction therapy? It is because after the tooth extraction, we can place into the socket whatever biomaterial. We can do whatever great sophisticated surgeries, but we are able to preserve the ridge only to a certain amount. It's never 100%. For this reason, partial extraction therapy, because partial extraction therapy has a goal to maintain the ridge dimensions after tooth extraction 100%, almost 100%. Why partial extraction therapy? If we are long enough in this job, we see our implants after a few years in this situation, on the buccally, on the lingually, and we get nervous. When are we going to see implant treats? Are we going to do connective tissue graft? What are we going to do? And situation that develop in 2 or 3 years after the implant placement and prosthodontic treatment, everything looks more or less fine, but then after a few years, some recessions, implant treats showing peri-implantitis. And this is what we see on a regular basis. I see it daily. This is because, and this is the most important slide of this lecture, alveolar bone is a tooth-dependent structure. Alveolar bone depends 100% of the tooth. It develops with the tooth and it disappears, the biggest part of it, when the tooth is extracted. I guess you hardly attended a lecture without seeing this slide. It is what gets resorbed. It is the buccal bundle bone. Buccal bundle bone because it is a tooth-dependent structure. There are three sources of blood supply to the buccal bone. What do we have? We have the buccal bone itself. It is in more than 80% of all patients, the buccal bone is less than 1 millimeter thickness, less than 1 millimeter. This is all cortical bone. There are hardly few blood vessels there. We do have periosteum and we do have periodontal ligament. We have learned when we are doing post-extraction implant that we shouldn't elevate periosteum, because if it's elevated once, it takes about 48 hours until anastomoses are built. This is about periosteum, but nevertheless, we still see recessions after post-extraction implants. And it would be great if we could maintain periodontal ligament, if we could take out the tooth, but not periodontal ligament. And this is the idea behind socket shield. Partial extraction therapy, partial retention therapy. It is submerged root with intact periodontal ligament. And this is socket shield therapy, where only at the buccal part of the root membrane socket shield is left in the socket in order to maintain the periodontal ligament. The first study published about socket shield was in 2010 by Hürzeler. Meanwhile, we do have good amount of the literature to this topic. One of my favorite papers is this from Boimer from 2017, showing what? Showing then mean orofacial change is only 0.37 millimeter after 5 years. He has done volumetric study, the scanned models and measurements and comparison, only 10 cases, but followed up meticulous for 5 years. And in average, there is only 0.3.7 millimeter resorption in the bucco-palatal direction. And let's see here, it is about the recession, implant recession, 0.33. And you can tell, well, there is recession after 5 years. Yes, there is. But look at the adjacent teeth. They developed even more recession. It is because it is a natural aging process. And with partial extraction therapy, this is for sure, we maintain the rich dimension predictable. We have results now for 10 years. I started with partial extraction therapy in 2015, and I don't see any changes. And I'm pretty sure, and I'm sure you are going to be sure after this lecture too, that it's going to be stable after 10 years, after 20 years, after 30 years. Absolutely no changes, no recessions, no collapse of the tissue. Now, let's talk about root submergence therapy. Uwe, may I ask you now to ask the question to the participants which kind of partial extraction therapy they have already performed?
Yeah, just a second. I must, just a second.
Yes. In that time, I'm going to start to talk about submergence therapy.
Yeah.
Root submergence. Mm-hmm.
Okay. Now we come. So the question is, have you performed some form of PET procedure?
Yes.
All participants, please answer now. So yes, you have, but very few, or yes, quite regularly, yes, many, or no, none at all. The answers come in quite quickly, Dr. Pohl.
Great,
Just
great.
a second.
Yes.
We have now almost 60, and you'll be surprised. Okay, now I close and I share. So the majority has not made any PET before, none at all. Many have been done, but and also yes, but very few. 24% already have done it, but very few.
Very nice. Then you are on the right place, because root submergence therapy, it is, I think, the modality of partial extraction therapy to start with. It's very, very easy, and you can get confidence. Root submergence therapy and Pontic therapy. Root submergence therapy can be done for vital roots and for non-vital roots, but with successful root canal treatment. Let's say the decision, can I perform root submergence therapy or not? It is like the decision, can I place a crown onto this root or not? Is the root vital, or is the root canal treatment successful? If there is some periapical pathology, if the root canal treatment is not fine enough, then we should retreat the root, or we should do a Pontic shield preservation, but we are going to talk about it. Okay, it is for vital roots and for non-vital roots with successful root canal treatment. Now I have to apply again your trick, Uwe, because it seems each time after you question something, the audience, my presentation stacks. So I'm trying to get out of it. Okay. What is interesting with root submergence therapy, it is very old therapy. It is 50 years old. Already 50 years ago, clinicians have done clinical studies, animal experiments, histologies with root submergence therapy. They simply realized if the roots are left in the ridge, that the prosthesis has so much better hold, so much better support, because the roots left in the ridge maintain the ridge dimension. But it was completely forgotten. Unfair, but it is like it is. It was forgotten until Dr. Salama and his group in 2007 published this beautiful paper, this beautiful case in Journal of Periodontics and Restorative Dentistry. Look at this implant bridge. Look at this tissue, papillas, maintained so beautifully, thanks to this submerged root between two implants. And this is how partially extraction therapy restarted. It is also Filippi. He's very famous in traumatology. Filippi stopped in 2001 to extract ankylosite roots. To destroy the roots and the surrounding bone. You know how it looks like when we take out ankylosite roots. No, instead, he cleaned the root canal content and submerged the roots. What happens with the roots? Replacement resorption. And he simply waited before the bone was built and he could place implants. For root submergence therapy, how we perform today, if the tooth is not ankylosite, is different. There is a periodontal ligament. There is not replacement resorption, but this is completely maintained ridge dimension. When I submerged for the first time the vital roots, it was the first full arch, full pet, full guided case. And when I submerged for the first time the vital roots, I wasn't very peaceful in this night. It is somehow looking at this exposed pulp and putting only connective tissue grafts over it and going home and sending patient home. It was like sacrilege. My heart was beating like palpitis. But if you know literature, if you know biology, then actually, if the procedure is done properly, it works fantastic. I have submerged so many vital roots, and the literature is showing it, and haven't seen complications. Once I had, unfortunately, opportunity to do re-entry for submerged vital root. It was because the left incisor implant was lost, it was a failure, and the central incisor was submerged. Look at this rich dimension, perfectly maintained. His dual zone implant placement. What a difference. And vital pulp. This is what the literature is saying, what our biology knowledge is telling to us. We are going to find a vital root when we reopen the site. Nothing is going to happen. In many, many cases, I have combination different modalities of partial extraction therapy. Here, shields for the lateral incisors and 2 submerged roots for the central incisors. On the very beginning, when I started 5 years ago with root submergence therapy, then I used to cover them with connective tissue grafts. And in this case, I needed connective tissue grafts also for posterior areas, and I didn't want to prolong surgery any longer. I had some PRF membranes, and I placed a double layer over the submerged root, what I'm doing nowadays regularly. There is no difference in healing. This is 3-4 weeks after the procedure was done. Same beautiful maintained dimension and beautifully completely covered the roots, both with PRF membranes and with connective tissue grafts. How should this procedure be done technically? It is always about biological width. It's nothing new. We always need at least 2 millimeter, better 3 millimeter. We need 2 millimeter, 3 millimeter between our submerged root and the future pointing base. We need this submerged root to be covered with soft tissue. And on the very beginning, it's very handy to prepare in advance provisional bridge with pointing, with ideal dimensions. We want to have a nice emergence profiles. We don't want to have a pointings in front of our ridge. We can prepare a pointing and submerge the root accordingly. It is, if we prepare ovate pointing, the root shape is going to be concave. These are requirements for the root submergence therapy. It is, as I already mentioned at the beginning, for the vital teeth or for the teeth with successful root canal treatment. Only if the buccal wall is intact. In generally, the partial extraction therapy is only for the teeth with socket type 1. Only for the teeth with the socket type 1. It means when the buccal bone wall is intact. It is for the teeth without intrabony periodontal defects and with stable and immobile roots. They shouldn't have mobility bigger than 2. Let's focus now on the major topic, what about everyone is talking. This is socket shield with implant placement. Implant can be placed immediately after the socket shield procedure is done, or it can be delayed. Implant can be placed after 3 or 4 months, dependingly. It can be that there is a huge periapical area. We cannot achieve enough primary stability. There is a alveolar nerve. We don't have more than 2 millimeter. There is a tooth with recession. In these cases, we want to delay implant placement, but more often we place implant immediately when socket shield procedure is done. And you know, if the socket shield would be simple, non-resorbable grafting material that doesn't cause any foreign body reaction, it would already be great, because the heart rich volume would be maintained. But socket shield is much more than this. Socket shield has a periodontal ligament giving blood supply to the buccal bundle bone. Partial extraction therapy is still looked with the big eyes. And the most common questions are about the mid and long-term results and what happens between implant and socket shield. For this reason, we came together in this partial extraction therapy dental XP research group to do multi-center studies, to exchange our experiences and our opinions. And we are really very active in our WhatsApp group. We cannot have so many mid and long-term results because the first paper, proof of principle, animal study, was published in 2010. It takes time. But nevertheless, the Greeks group around Tsiorompas published in 2014 5 years results, great results, and then last year 10 years follow-up, retrospective clinical studies, 10 years after socket shield therapy. Again, great results. And Glukman, Salama, Dutoa from my group, they published up to four years in 2018. And here they haven't focused on partial extraction therapy superiority. Maybe I am going to focus more on it in my lecture. But they simply compared complication and failure rate between implants placed with socket shield to the implants placed conventionally or post-extraction placed implants, and they haven't found any difference. What happens between implant and socket shield? This is my favorite topic. I can talk for 3 days about it, but let's say shortly. We do have few animal histologies, all of them showing bone between implant threads and the socket shield, and we do have 2 human histologies showing bone between implant and socket shield. Histology is from Chuck Schwimmer from our group, and the human histologies, this is an implant that was 5 years in function and without any problems, showing the bone between implant and socket shield and about 3 millimeter connective tissue in the coronal area. Jorge from our group, who is going to publish his ebook about partial extraction therapy very soon, I can really recommend it. Well, Jorge has done animal histologies, and this is the best histology that I am showing here. This is what we don't see regularly, what we see very seldom, but even this is possible. Look, socket shield and bone over the socket shield. Great. This is human histologist from Chuck Schwimmer. By the way, he had yesterday at AAP podium discussion pro and contra socket shield or partial extraction therapy with Denis Tarnov, and he has done great job. Congratulations, Chuck. Chuck's histology showing bone between implant, the black is implant, and here you can appreciate bone. Let's see some cases. This is one of my cases, and we will not do now questioning because I have to interrupt my presentation after it. But just look into this picture and try to figure out where is the implant. And I guess you are going to guess one of both of central incisors, because White aesthetic is telling us that one of these central incisor could be an implant. But which one? Let's see. And this slide I put together 5 minutes before this webinar, and thought about asking you to see where is the implant. All of these are implants done with partial extraction therapy, all of them single implants with socket shield, and it is really, really difficult, if not impossible, to tell where the implant is, mostly because it doesn't have any problems. It must be a tooth or implant with socket shield. Let's go back to the case. It was the left central incisor. This is CBCT of the patient. Close-up view. Beautiful young patient. For this patient, I prepared 2 guides. One guide for socket shield preparation, and the second guide was for the implant placement. This is very handy. I'm going to explain it on another case that I've done live surgery for in with Darian together. The first guide is to give a direction for socket shield preparation. It goes through the root canal. So I utilize only the first drill to have direction for socket shield preparation, and the second guide is for the implant placement. And now when we are looking at these CBCTs, don't give up partial extraction therapy in the cases where you can do partial extraction therapy. Many, many times we cannot tell on CBCT if there is a buccal bone here or not. In both of these cases, there was a buccal bone. And when we look in CBCT, we cannot be sure. I ordered both of these guides in BEGO, and it is really nice. It simplified so much procedure, because the first drilling we go through the root canal, and then we can separate brain guided the root in distal direction and take out the palatal part of the root. It simplified the procedure, especially for the canines and central incisors. They have very, very often very long roots. This is how socket shields looked like when they are prepared. Let's go back to the case with the left central incisor. This is implant placed with some gap to the socket shield. We try to have this gap in order to have space for our prosthodontics. I'm going to explain it. It was immediate provisional was done for this case. This is how it looks like few days afterward, and patient, she didn't come back for 18 months. She was so happy with provisional. This is how it looks like, and how this emergence profile should look like. And the case was finished. And you can negotiate for the patients with the thick biotype and tell, if I place a post-extraction with dual zone augmentation, with connective tissue graft veneer grafting, I can achieve the same results. Maybe if the biotype is thick, but there are some situations where partial extraction therapy You cannot replace it with any other therapy. Look at this initial situation. Imagine we take out this incisor. We are going to have a complete ridge collapse, not only horizontal dimension. You're not going to have any vertical dimension. And how many of us can perform and can Curie technique internal approach for the vertical ridge augmentation be performed for such a tiny site? But here I succeeded to perform a tiny socket shield and to place implant. This is how it looks like after 6 weeks healing. Look at this keratinized gingiva. It's not only about the bone, it's about keratinized gingiva. And this is how the patient looks like after the prosthodontic was done. This is CBCT superimposition. Look carefully at this video. This is superimposition before tooth extraction and after implant osseointegration. And look at the buccal bundle bone peak. Nothing happens. Everything is here like it was before the partial tooth extraction. These are socket shield indications and contraindications. If we keep socket shield indications, and if you perform socket shield how it should be done, there is no other therapy that compares. Indications are intact buccal wall, no intrabony periodontal defects, stable and immobile shield, and contraindications, very logical. If the buccal bone is lost, no socket shield. If there is vertical bone loss, no socket shield. Tooth mobility 2 and more, no socket shield. Or if this buccal portion of the root, this root membrane, is not intact. Let's see, why do we need partial extraction therapy for multiple implant sites and for adjacent implants? This is why we need partial extraction therapy for adjacent sites and multiple implants. If you can negotiate about single implant site, I cannot anymore, but if you can, you cannot negotiate about adjacent implants, about superiority of partial extraction therapy for adjacent implants and for the multiple implant sites. Look at this ridge after partial extraction therapy. Lojo, it is not only for aesthetic, it is for the function. Here, different modalities of partial extraction therapy were performed: Pontic shield, socket shield, root submergence therapy, root submergence therapy. We cannot always perform socket shield, not for each implant, like for this implant not, but adjacent is root submergence. Root submergence, you are going to see advantages of it. And look how it looks like 2 years after the treatment was done. What do you think? Is the patient complaining about food impaction in these areas where partial extraction therapy was performed, or in the areas where no partial extraction therapy was performed? What do you think when the patient for follow-up? Should you feel more nervous looking at these sites or these sites? This is what Salama and his group put together, the numbers they put together from the literature. We know that between two adjacent teeth, we can count on about 5 millimeter papilla high, on about 5 millimeter vertical soft tissue high, from the marginal bone to the top of the papilla, 5 millimeter. What is if we have an implant? If we have an implant, then we count on 4.5 millimeter papilla high, because this papilla high is not determined by the implant, it is determined by the adjacent tooth. 4.5 millimeter, it's not bad. We can camouflage it with nice prosthodontics. It's only 0.5 millimeter less than between two adjacent teeth. But what is between two adjacent implants? there is no bone pick from adjacent tooth. We only have, we don't have bone pick from adjacent tooth. We have bone between two adjacent implants. And even if the implant design get more sophisticated these days, we still do have less low bone level between two implants than between an implant and adjacent tooth. And now I have to talk about this picture because my presentation is again a little bit stuck, but we are going to bring it to the life. Excuse me. So what are we missing are bone picks from adjacent teeth. And this is what we do see between two adjacent implants, missing papilla. And here I don't talk about two central incisors. It's not big to maintain papilla between two central incisors implants. The problem is central incisor and lateral incisor. Lateral incisor and canine. This is what are we talking about. We don't have a bone pick maintained by adjacent tooth. And we count only on 3.5 millimeter papilla high. For this reason, we do have these missing papillas. This is one of my cases. Everything done, implants were placed in 3D position, connective tissue, grafts, hard tissue, everything, tissue level implants, and still the papilla is missing between central and incisor. So we can then tell, okay, but between two adjacent pontics, we can count on 6 millimeter papilla high. And if it's about multiple sites, then I'm going to place my pontics in between central and lateral incisor, and the problem is solved. It is, but it is not, because the count is 6 millimeter starting apically than if we had a tooth here. It's not the same. And this is what we can solve with partial extraction therapy. Even if we cannot place an implant with socket shield, on the adjacent side, maybe we have implanted socket shield or from the root, or we do have a pontic shield. And all of them they maintain this peak of bone. And this peak of bone gives papilla. So simple. For this reason, partial extraction therapy for multiple sites and for adjacent implants. And it's not all about the bone, it is about the soft tissue. And this is what we know for many, many years from Berglut and Lindner. This is the main difference between peri-implant site and the tissue, soft tissue around the tooth. There is no blood supply coming from periodontal ligament vessels. For this reason, there is very, very little blood supply in this very, very critical area around the implant neck, in this area where all problems start. But if we do have a C-shaped socket shield, if we do have socket shields, we have more periodontal ligament, at least half of periodontal ligament. Then we have more blood supply. And not only blood supply, we do have more dentogingival fibers, and they are very, very important to maintain the papillus and soft tissue. Look at this case. It is about the central and lateral incisor. This is before tooth extraction, and this is with provisional restoration. The patient didn't come back for almost 18 months. She was so happy with provisionals. And look at this initial situation. There is a papilla here. Here you see some recession. And look at X-ray. We already have about 3 millimeter bone resorption between central and lateral incisor. And imagine horror scenario if we do traditional approach and extract completely both of these teeth and place implants. it would be bye-bye papilla. This is for sure. This is CBCT of this situation. These are absolutely not cases to start with partial extraction therapy, with socket shield. I told on the very beginning that periodontal pocketing is contraindication for partial extraction therapy. But look, these pockets are on the palatal and no pocketing on the buccale. No active periodontitis on the buccale. So I felt comfortable doing partial extraction therapy. And in this case, I utilized the teeth because they were vital to produce a dentin autograft. And dentin autograft was utilized to fill the sockets and to give, on the begin, mechanical support to the papilla. Why dentin autograft? This is another topic, but I want to show you these are preliminary results of my study, CBCT analysis for dentin autografts for rich presentation. And here you can see in concrete case where the teeth were simply extracted, flapless extraction, dentin autograft grafted, covered with PRF membranes, no surgical skills required, absolutely no. Look at this CBCT superimposition. Look, we gained palatal bone height. And this is in summary what I get from 56 sockets filled with dentin autograft. Improvement in the labial bone height, lingual bone height, buccal bone height. And of course, some horizontal ridge resorption because there is no grafting material that can maintain the ridge dimensions completely. Only nowadays with partial extraction therapy. Patient got immediately provisional crowns. Now I was too fast. And as I already said, she didn't come back. And this is then the final result. You can appreciate the soft tissue, the papilla. I really feel safe when this patient comes. And this is one of my patients that I'm trying to recollect, to do recall, to measure the papilla height between two adjacent implants. And I can tell you that results look more than good. Like all other therapies, there are complications with partial extraction therapy. The most common complications are internal shield exposure, external shield displacement, and shield fracture could happen. Look, this is external shield exposure. It means that with time, it is mostly during the healing, the shield like perforates the gingiva. The therapy is more than simple. It is simple, grind it. You take a burr and this part of socket shield is ground, and this is how it looks like then after the healing. I had a very serious complication once with one case. I won't tell now the entire background, how this case developed, but anyway, it was the lateral incisor, and lateral incisor sockets are very narrow. So I didn't notice that the shield was fractured during implant placement. And this is how it looked like when the patient came after 4 months. She didn't complain because there was a drainage here. Somehow it wasn't painful. But this is what can happen. For this reason, I utilize Densabos for implant site preparation because there is no chattering with Densabos. And whenever possible, I place my implant without contact with socket shield. Sometimes it's not possible for the lateral incisors and for the low jaw incisors, but then we should be carefully. Okay, luckily in this patient, this is lost implant and lost sight, not only lost implant. Luckily, I've done shield for the canine, so I had a nice area to place an implant, and the lateral incisor was then appointed. Then we do have internal shield exposure. Internal shield exposure would mean that there is no soft tissue covering our socket shield. There is no this 2 to 3 millimeter distance space between our socket shield and prosthodontic components to be covered with soft tissue. And I prepared this animation and this is what I showed by my last lecture 2 weeks ago in IDEA, because I didn't have any case with internal shield exposure. But the day before yesterday, one patient came absolutely without any symptoms. And then when we took the crown off, I've seen there was internal shield exposure. We don't know if it has consequences, but this is not health for me. It is not healthy. So I reduced this socket shield, and the soft tissue is going to grow over it. It is not a problem at all. This is one of the most famous slides from partial extraction therapy photography from Richard Martin from our pet group, showing this space maintenance that we should have between socket shield and our prosthodontic components. We should take care to utilize the T-bases with a higher collar. What I do to prove if I have enough space between prosthodontics components and socket shield, I love to place multiplex abutment to check the space, because multiplex abutments, they have a pretty dimension. And then I think if I have a space between my multiplex abutment and my socket shield, then I'm going to have for all situations. Now, I want to finish with one case. This is the right central incisor with root resorption, deep caries. The patient was young. For this reason, this hand X-ray. So now you are going to see a socket shield preparation. The right central incisor was hopeless. So the first step is to level the tooth on the gingiva level. Then we follow the root canal all the way to the apex. It must be apex root canal content. They must be removed. No gutta percha, no any root canal filling material, no diseased dentin should be left, no apex. This is all risky. Only healthy buccal socket shield root membrane should be left in place. So I reduce socket shield in order to have space to take out the palatal part of root. If the socket shield is get unstable during this procedure, you must take it out. You must take it out and proceed with normal post-extraction implant placement. Degranulation, I've done also laser therapy here. If I'm not sure that all periapical inflammatory tissue is removed completely, then I add apicoectomy. Implant preparation with I always prepare with denser burrs. In this case, PRF was utilized to fill the gap, and instead of filling the gap, I prefer to fill the socket with material and then place my implant. Socket shield is on the bone level and implant is 1 millimeter underneath the socket shield. These are the general rules. And of course, there are individual situations, but it is much more than 45 minutes lecture. This case is 3 years old now, and during you enjoy this beautiful view, I would like to invite you to come in October next year to a beautiful event in Croatia, in Dubrovnik. It is Divas in Dentistry Congress. We had our first event last year in Berlin, and it was great. It was so much fun, and we learned so much from each other and motivated each other. We are from all over the world, from Spain, Venezuela, Brazil, States, Croatia, Portugal, Spain, Pakistan, India, Nepal, from Venezuela, I told it already, all over the world. And it is not only divas in dentistry, it is also divas in dentistry. If you want to learn a lot, I'm in scientific board and we put a really great program together. Come in October, Dubrovnik, Croatia. And I can proudly say that BEGO is our first and gold sponsor of our event. You see divas and divas, great topics, great agenda, looking forward to it. So now the time is over. I would love to see if there are some questions.
Hello, we are back here. First of all, Sinejana, yeah, that's why you are the queen of the partial extraction therapy. I believe there's one cannot have more experience than you in this topic. You really make it fantastic.
I really do have a lot of experience. I've done more than 300 socket shields procedures and beautiful results.
It's a pleasure. We are quite on time now. We want to keep the session on time. We would like to ask you if it would be possible if we send you the questions of the participants, and we have some, and when you have time to answer one or another, if it would be okay
Of
for
course,
you.
I will do it immediately, but we still have 3 minutes.
Okay, that's why we some questions we have, and the first one: should the implant be in contact with the socket shield?
This is what I explained. The histologies showing bond between implant and socket shields are all histology where the implant is in contact with socket shield, but it can be dangerous. It can be dangerous, especially if the implant is placed underneath the socket shield, 1 millimeter underneath. We don't have place for our prosthodontics. This is what I explained now at the end of the lecture. It is better to have a gap. We are safer if we do have a gap.
What if the socket shield becomes mobile? Can we still preserve it or not?
No, we should take it out. We should take it out and go traditionally, conventional post-extraction implant placement, dual zone augmentation, connective tissue graft. No, if it gets mobile, the periodontal ligament is destroyed, and this is foreign body. You are going to have complications.
Thank you very much. For the root submerged technique, do we need to perform RCT first?
If the root is vital, no. If the root is not vital, yes. Or if the root canal treatment was not done properly before, it should be redone. Or you do Pontic shield. We can always perform Pontic shield if the tooth is mobile. For the root canal treated teeth, I more often perform Pontic shield therapy. Vital root submergence.
In measurement, how much root structure can be left submerged?
In measurement, how much to have a prosthodontic space, to have 2 to 3 millimeter between the future Pontic base and submerged root. 2 to 3 millimeter between, concave shape.
Okay.
And now I think it's time to say goodbye. And I'm going to answer the questions right now. How many?
We would still have around, I would say, around 10 questions.
Okay.
Yeah, this was quite that we imagined for the presentation when we were speaking, because the topic is so nice for us as colleagues to know that it's something not new. As you said, the technique has more than 10 years, but something very excited for us, the technique. So it's still raising lots of questions, and we were imagining this. So if we can send you the questions, it would be a pleasure for us.
Of course.
I believe, Uwe, you can come for the end of the session. You that came on the backstage for so much time. Once again, to thank you, Sinejana, so much for being here. I would like myself to thank you, all the participants, and I left the word to you, Uwe, as for an ending.
Yeah, thank you so much. That was so extraordinary. It was a great lecture, and I can see from the people who attended, they were very attentive. So excellent. Thank you so much. One thing I would like to add, where we also will have the pleasure to see you in the next year after your event, the Divas in Dentistry, we will have this side, the Art of Implantology. It will be from the 16th to 17th of October next year in Amsterdam, and you can, as from 1st of January, you can enroll to that, and you will have the pleasure to listen to Dr. Pohl again. It's been a pleasure. Thank you very much to everyone, and bye-bye for now.
Bye.
Bye-bye.